Perfect.
सर किसी और ने ज्वाइन कर लिया था एज होस्ट.
अच्छा,
कैन वी
तो
रीस्टार्ट? कैन वी रीस्टार्ट द थिंग्स
हाँ
ऑन
सर,
द स्लाइड?
तो अभी आपको दिख रहा है सर,
या
मैरो स्लाइड दिख रही है
एवरीथिंग.
सर?
या
सर स्लाइड दिख रही है सर?
जी
Yes,
जी जी
yes,
सर.
it is visible now.
Perfect. So the topic is of man, machine, and anemia. Again, once again, thank you, Dr. Pawan, and thank you, Dr. MP Jain sir, and thank you, Dr. Ajay Arora sir. We are going to talk about some few things on the ABC of CBC. First question is, when at what platelet count can we do a bone marrow aspiration? So the answer to that is 0. At a 0 platelet count, you can do a bone marrow test. Bone marrow test is done from aspiration, is from the posterior superior iliac spine, so need not worry. The only contraindication for the bone marrow test is either amyloidosis or hemophilia or on anticoagulation. Just remember that. Always remember, anemia is a clinical sign of disease. It's not disease itself. Diagnosis is not that simple, and very important common things have to be seen through. There is a WHO Health Organization and Center for Disease Control values for hemoglobin, which we need to remember. Now, starting with this, what is this looks like, sir? Very simple. This is example of a normal sample report. These are the parameters, you say 27 parameters which are there, which comes on a CBC report. Generally, what do we get, sir? Generally is, what do we get? We get only the printed report. And printed report might give you only HB, TLC, DLC, MCV, MCH. So please remember, the minimum things which are required is WBC, neutrophil, lymphocyte, monocyte, eosinophil, basophils. Then you have to have a hemoglobin, RBC count, hematocrit, MCV, MCH, MCHC, RDW, platelet count, and mean platelet volume. This has to be printed and has come to you, because these are the most essential parameters of what you need to see. On the left hand side, if you see, is the scatter plots, because these are the scatter plots like this one, which helps you to diagnose what we are seeing. This is the side scatter and this is the forward scatter. As the cell is bigger, there will be a forward scatter. As the cell has got nuclei, neutrophils, has got granules or rods, it will be a side scatter. So you can actually see this, and we are developing an AI model to predict from these side scatters to differentiate between various leukemias. So this is what you routinely get in a day-to-day practice. Reticulocyte, why I was telling about reticulocyte? Reticulocyte is the mature form. When the RBCs are getting mature, before the final product of RBCs, the reticulocyte comes in. If the reticulocyte count is high, do not go into reticulocyte production index. Please do not go into that. Reticulocyte divided by what is the hemoglobin and then divided by 2, hyperproliferative. Don't go into that. If the retic is high, it means your bone marrow is producing, might not be producing to an extent where a hemoglobin is required. So please remember that. And these are fluorescent ratios: low fluorescent ratio, medium fluorescent ratio, and high fluorescent ratio. It talks about how and what kind of a reticulocytes you have. And reticulocyte has also got hemoglobin. So if you use ret hemoglobin, this is the final ret hemoglobination of a reticulocyte. The ret hemoglobin actually helps you in differentiating iron deficiency anemia from anemia of chronic disease. It is a very valuable parameter where majority of people do not respond, is the patient on the dialysis, because on the dialysis, erythropoietin is less, hemoglobin is low, you don't know whether there is iron there or not. If the ret hemoglobin is low, it means iron deficiency is there. You need to give erythropoietin as well as the ret hemoglobin. So very, very important. If the ret hemoglobin, reticulocyte hemoglobin within the reticulocyte is a ret hemoglobin, which we need to remember. This is the IPF. Now platelet comes low. What do? Is it a production defect or a distribution defect? Somebody said there is a ITP, immune thrombocytopenic purpura. How do you know it is immune thrombocytopenic purpura or it is a falsely low value? See this. This is an IPF. This is immature platelet fraction. The reticulocyte, equivalent of reticulocyte for the platelet is immature platelet fraction. If the immature platelet fraction is low, it means hypoproliferative, which is aplastic anemia. If it is high, then it is ITP or immune thrombocytopenic purpura, where there's a production is normal, but the distribution is a problem or getting destroyed. Then there's neutrophil lymphocyte ratio, lymphocyte monocyte ratio, and platelet lymphocyte ratio. These are all markers, friends, for the inflammation and the sepsis markers. Neutrophil lymphocyte ratio predicts inflammation and a biomarker for several malignancies. Similarly, the rest of the things are also there. High fluorescent count, immature eosinophil counts, immature reticulocyte fraction. These are all important tools in a multi-speciality hospital which is required. One is very important is the fragmented red cells which comes in, because certain times you can have a schistocytes which can be having a red cell fragmentation, high red cell fragmentations, which tells you that you do not give platelet, but you need to do plasma exchange for these people. And these are the other parameters which are there in this case. So now let's come to the cases. Like we have got 4-5 cases. 55-year-old male presented with complaints of gradual progressive weakness and tiredness for 6 months. Ma'am, can you switch off your this thing? Thank you. There was no organomegaly and his hemoglobin 1 year back was 13. So say now what we are seeing here. HB is 6, hematocrit is 19, 6 3s are 19. Hematocrit is 3 times. I will show you the rest of the parameters later down the line. But the MCV 55, which has to be 80 to 100, it is small, microcytic. RBCs are small. MCH is 18.5, it should have been 28. It means RBC has got less of hemoglobin, which is mean corpuscular hemoglobin. And then the MCHC is 24.7, RDW is 21.2. Red cell distribution, which means 80 people sitting on this forum are of different size and shape. Means anisopoikilocytosis. It means some RBCs chote hai, kuch bade hai. There are some smaller size, some bigger size. That is RDW, which is prolonged. WBC count is normal. RBC count is low. Retic is 5%. So, microcytic hypochromic blood picture has got 5 differential DR. First, iron deficiency. Second, thalassemia minor. Third, lead poisoning. Fourth, anemia of chronic disease. And fifth, X-linked sideroblastic anemia. Sometimes copper deficiency can also lead to microcytic hypochromic blood picture. That is why we need to remember the differential for this. Now remember the one-liners. Low MCV, low MCH, prolonged RDW. Low MCV, low MCH, prolonged RDW is iron deficiency anemia. Low MCV, low MCH, normal RDW. This RDW, if it is 14, that is normal. Up to 15 is normal. If it is normal, that means all the red cells are of same size and shape. There is no anisopoikilocytosis. And when there is no anisopoikilocytosis, it means all the RBCs are small. That goes into thalassemia minor. And this retic is high. It means if the reticulocyte count is high, there's a chances of a iron deficiency anemia. And that is what out of the 5 differential diagnoses we have to remember. In this also we have to remember we do not give blood to the patient who has come walking to you. It means patient has been well compensated. Hum kehte hain 10 ka dam because we have started living at a hemoglobin of 10, but we want hemoglobin of 12 in females. And this is how quickly within 30 seconds, even 5 seconds, you can make a diagnosis what it looks like. Hemoglobin 6, remember, is not an indication. The indication for transfusion is coronary artery disease, CCF, or patient is on sepsis or undergoing any surgery. Otherwise, there is no cutoff limit for any hemoglobin to transfuse at level. So this is what we remember. RBC count is 5 million. Hemoglobin is 5. Hematocrit is 45. So remember, A into B is equal to B into 3 is equal to C. So 5 3s are 15, 15 3s are 45. This is the rule of thumb. Please remember, if these indicates are micro, macro or hypo, this will not be there in the normal thing. Please remember, RBC count is 3 times the hemoglobin. 5 3s are 15 and 15 is hematocrit is 45. Why you have to remember? In polycythemia, you have to maintain a hematocrit of 42, 45. 3 derived indices. These are calculated indices. This is calculated by the machine through the impedance methodology or the flow cytometry. This is measured. Now, what does a machine calculate? So, MCV. MCV is C divided by A. C divided by hematocrit divided by RBC. C divided by A into 10 is MCV. MC is mean corpuscular volume. MCH is B divided by A. B divided by A into 10 is 30. And MCHC is B divided by C into 100 is 33%. Please remember this thumb rule for these MCV, MCH, and if they are not obeying, it means there is something wrong into it. Reticulocyte, we have already talked about, less than 2% is hyperproliferating. And this is what the reticulocyte count looks like in supravital. And Leishman stain, very, very important, because if you're looking for a golf ball appearance in alpha thalassemia, you can do on a supravital stains. So reticulocyte production index, I've told you not to be utilized in the clinical practice. Why? Because it gets you confused. Retic is high, it means bone marrow is producing. So differential diagnosis is iron deficiency anemia, beta thalassemia trait. The best friend for medicine is the pathologist. So please remember, MCV, MCH is very, very important component of your clinical practice. The most common cause for thrombocytosis in the clinical practice is iron deficiency anemia. Thrombocytosis, if the platelet count is high, the most common cause is inflammation or iron deficiency anemia, and iron deficiency anemia is the commonest cause in these cases. So this patient has got a low iron, low hemoglobin. If any male above 50 years of age has got low hemoglobin, please do not shy away from putting the endoscope and colonoscope. That is where you land up with a problem. If you don't do that, then the stool occult blood was positive, patient was carcinoma colon, and he was operated at stage 1 and he became better. So please remember, in males, if there's a low hemoglobin and there's an iron deficiency, please do put in the scope. Endoscopy, colonoscopy should be must. This is very important. MCV, iron deficiency, important. Ferritin has to be less than 45. Ferritin 42 to 46 and ferritin more than 100. We can discuss this. These are the transferrin saturation. Microcytic hypochromic blood picture, iron deficiency anemia is the commonest cause. Less than 33 iron deficiency ferritin, 33 to 270C, do the TIBC. Total iron binding capacity, if it is high, means body is trying to keep the hemoglobin with them, and that is high, that's iron deficiency anemia. If it is low or normal, we need to see the bone marrow iron content to prove it. Still, the gold standard is the bone marrow iron content, which is the gold standard for iron deficiency. So IDS special test, serum ferritin has to be low, which is a storage form, which has to be done empty stomach. TIBC is more than 400, which means total iron binding capacity. The protein has bound iron more and they want to release it to the erythrocytes. Serum iron is low, percentage saturation is low, and the bone marrow iron stores are absent. So please remember, when you are dealing with an iron deficiency or suspecting an anemia, please get these blood tests urgently. IDS summary, this is the IDS summary. Hypochromic blood picture, reticulocyte count may be high, ferritin is low, TIBC is increased, serum iron is low, and response to iron is excellent. These are the smallest thing which we need to remember. We will not talk about the treatment part right now. We'll take it some other day. Second patient, SB is a 25-year-old female from West Bengal, was selected for becoming a pilot. At her medical test, CBC was found to be following. I will give you 5 seconds to make a diagnosis and put it on the group. What diagnosis do you think? HB is 10, MCV is 55, MCH is 18.5. Now see 18.5, it is still microcytic hypochromic, but this time RDW is normal. This time RDW is normal and hemoglobin, and you'll see the RBC. RBCs are higher. What should have been low? It is higher than the rest. So it means the RBC counts are raised. So RBC counts are raised. Retic is not raised. It means we are thinking of some hemoglobinopathy. So low MCV, low MCH, and normal RDW. Normal RDW is thalassemia trait. The best test to be done is all the things were normal. Next test was HPLC, and the HPLC shows A2 value of more than 3.5, which is 5.3. So please remember 5.3 A2, it is about, means that there is a thalassemia trait. So thalassemia trait में क्या करना है? शादी के बाद और बच्चा पैदा करने से पहले thalassemia की जांच करना mandatory है. So even if you're not doing an HPLC, how CBC helps you to diagnose it so early, a beta thalassemia trait. So reassurance is what is required, and counseling before marriage. Now, this is a similar case in which the last time we were dealing with a microcytic hypochromic blood picture. Now, this young 36-year-old female comes with lethargy, weakness, depression. Now, look at the MCV in this. Hemoglobin is 10, MCV is 124, MCH is 40.5. It means it has gone more. Mean corpuscular volume has gone bigger. It means the cell size is much more bigger. MCH is 32.7, platelet is normal, NRBCs are there into this. What is that diagnosis now looks like? Now the MCV is bigger. Now the bigger is bigger, means red blood cells have become larger in size. And when it is larger, what it looks like? What it looks like? What are the differential when we have a larger hemoglobin? Okay, somebody has said macrocytic. Yes, macrocytic is the right word, not the megaloblastic, because it's a macrocyte. Macrocyte is not always vitamin B12. Macrocytic anemia could be of what all reasons? It could be alcohol. It could be autoimmune in nature. It could be hydroxyurea. So there's a drug, there is a liver, and there is a autoimmune hemolytic anemia. And yes, there is a vitamin B12 deficiency, which we need to remember. Vitamin B12 deficiency, remember one thing, MCV is high. Think about megaloblastic, think about MDS, think about drugs, think about alcohol, think about liver disease. These are the differential which we need to think about. And whenever there are NRBCs, it means the marrow is hypercellular. Marrow is producing very fast. And that is why the LDH is very important in these subsets of patients. And what does the LDH does? And what does you see? So tongue is bald. Tongue has got no furrows, no burrows. And on the right, you see a hypersegmented neutrophil, which means 5 segment, 5 lobe, 5%, 6%, 6 lobes, 1%. 6 lobe, 1%, and 5 lobes, 5% is the clincher for diagnosis for megaloblastic anemia. And this is what it looks like, a megaloblastic. Vitamin B12 was low. What are the other features which you have, which gives you a clue towards vitamin B12? MCV is high. There is an indirect hyperbilirubinemia. There is an indirect hyperbilirubinemia. Why? Because the red blood cells are getting broken down. The red blood cells are getting broken in the bone marrow. That is called ineffective erythropoiesis, and that is why you have got raised SGOT, SGPT, and a bilirubin, which is high, which is indirect in nature. And what is the most important thing, even if you can't do the B12 level, is the LDH, lactate dehydrogenase. Remember, lactate dehydrogenase, I will introduce you one word, LDH, which talks to you about cell proliferation. Means cell is being proliferated more. Cells are producing more and dying more. That is why the LDH is high. And high LDH, pancytopenia with high LDH can never be aplastic. If you see a high LDH, either it is B12 or it is some malignancy, which we need to remember. It is very, very important. Reticulocyte count increased on 7th day, hypersegmentation on neutrophil disappears on 14th day. Remember this, hypersegmentation goes on the 14th day. So pancytopenia, high LDH can never be aplastic anemia. High LDH, pancytopenia could be megaloblastic or could be leukemia, is what we need to remember. And this is how you generally tend to treat it. These are macrovalocytes and vitamin B12, which you tend to see. Okay. So next case, 50-year-old male visited his doctor, noted the white of his eyes appeared yellow. His father also had jaundice. It means this patient at the age of 50 years for the first time has been diagnosed with jaundice. He has also received it at the age of 22 also, but he didn't notice. And somebody said he looks yellowish. Yeah? He said, okay, it looks like yellowish. Okay. Now this time hemoglobin is 3.1, hematocrit is 8, RBC count is really low. RDW is 21.6. Reticulocyte is 22%. Now, apart from iron deficiency anemia, RDW has got no role, because the RDW means red cell distribution width is bigger. It means there's an anisopoikilocytosis. Now the hemoglobin is low. Should we transfuse this patient? The answer to that is probably no. He has come walking and the reticulocyte is 22%. Whenever the reticulocyte count is high, there's a hemolytic anemia. And it is said, if you don't like a hematologist, send a patient of hemolytic anemia to him. He will do 20,000 rupees test and give you a 5 rupees tablet, which is called steroid. Or he will not say, he will say a 1 rupee tablet called Folvite. Enjoy yourself. That is how you have, if you don't like this, you can always look into this. What is the next test? We have discussed it. What is the next test which has to be done? So I should congratulate Dr. MP. We have crossed 100 participants. So what is the next blood test? So the next blood test, dear all, is reticulocyte is done, 22%, peripheral smear. The next blood test is the peripheral smear, and which shows spherocytes. Which shows spherocytes. And the diagnosis clinching was father also had a history of yellowish discoloration, which is an autosomal hereditary spherocytosis. How we have clinched the diagnosis is on the reticulocyte count as well as on the peripheral smear. That is very, very important. And what is the treatment for hereditary spherocytosis? Either splenectomy or Folvite. So you don't need to do anything. And if these spherocytes would have been small, this would have been autoimmune hemolytic anemia. But then the father would have not had the history of this. Next case, 25-year-old female after a bout of viral infection presented with weakness in ER. CBC was ordered, hemoglobin 5, TLC 5,000, platelet 30,000. What is the next blood test? What is the next blood test? So the next blood test is peripheral smear. Because the hemoglobin is 5, how do we evaluate this? Platelet 30,000, female had ITP, blood hemoglobin has gone down. Second, there's an autoimmune feature which has happened, which has led to hemoglobin and platelet down, which could be Ivan syndrome. And the third is patient is having a leukemia or patient is having a TTP. That is why the hemoglobin and the platelets are low. TTP, MHA, microangiopathic hemolytic anemia is on the top of the recall, because in MHA you do not, or TTP, you do not give platelets. You only do plasma exchange. So what is the next test? Next test was LFT was done by the time it was coming. Indirect bilirubin of 8 grams. LDH was 3,000. Next investigation, peripheral smear. And the peripheral smear shows rouleau formation. Peripheral smear shows rouleau formation. This is typical of a autoimmune hemolytic anemia. This is a typical of a autoimmune hemolytic anemia. And this is the warm antibodies which has happened, which we need to give steroids and not the blood transfusion. So very, very important. Direct Coombs test was positive. Remember, Coombs test always has to be reported as 1+, 2+, 3+, or 4+. Do not take positive or negative. 1+ could be falsely positive even in a CLD patient, because the lining of the cholesterol lining of the RBCs get destroyed, and that's why DCT could be positive. The steroid was given, patient became better. 56-year-old patient presented with from Madhya Pradesh, 45 transfusion in 3 years, hemoglobin of 6.5, TLC 6,500, platelet 2 lakhs, LDH normal, reticulocyte count 0.6. So last 3-4 cases, microcytic hypochromic, macrocytosis, retic increased. Now the retic has gone down. Now the retic has gone down. What does it show? It shows it is not producing. So peripheral smear shows some erythroblast, neutrophil and erythroblast. This is the erythroblast and this is the neutrophil. Bone marrow aspiration biopsy was done. Bone marrow aspiration biopsy shows erythroblast, pro-erythroblast, giant pro-erythroblast, which is typical of a pure red cell aplasia. So patient did have the pure red cell aplasia. So अगर सारी चीजें बैठ जाए तो पैनसाइटोपिनिया, अगर प्लेटलेट कम हो जाए ITP, if RBCs कम हो जाए, उसका प्रोडक्शन कम हो जाए, that is called pure red cell aplasia. Patient had thymoma. He was operated for thymoma. on cyclosporin 6 months was doing well. So please remember, if you have a PRCA as an evaluation of anemia, you have to get the chest CT done to see what is happening there. So this is the typical approach of friends for anemia. Low MCV, MCV normocytic normochromic, MCV high is very common. The biggest problem is of a normocytic normochromic anemia. Very, very important. Pancytopenia, so high anemia, high SR, back pain, think myeloma. Unexplained renal failure, think myeloma. Okay. This is renal failure, endocrine chronic inflammation, and bone marrow infiltration has to be thought about. So this is how general picture of a normocytic normochromic arranges. Last two cases, I'll finish by next 10 minutes. This is the case of a pancytopenia. Look at the hemoglobin 6.2, TLC of 1.80, lymphocytes is 82. Platelets are 20, PS only shows lymphocyte. Please do not give steroid until unless we do not know what we are happening. In this, neutrophil lymphocyte ratio is reversed. Lymphocyte is more, neutrophil are less. We were talking about the RBCs, now we are talking about the TLC. Neutrophil lymphocyte ratio reversed. 82 of lymphocyte, neutrophil 18, peripheral smear does not show anything. And there's nothing called subleukemic leukemia, dear all. There's nothing called subleukemic leukemia. There is only leukemia. So you do a bone marrow test. Bone marrow shows empty. This is aplastic anemia. This is a emergency. You do not do only aspirate. Always do aspiration and biopsy together. And one should give steroid. The answer to that is no. Please do not give steroid to such patients. Next case. In this case, patient has got pancytopenia. The last patient also had pancytopenia. Steroid was given 2 years back. Nothing happened. This time differentials were never done. Look at the hemoglobin, TLC and platelet. No differentials were done. Spleen 2 centimeter. Rest of the organ systems were normal. So you have a pancytopenia, steroid given for 2 years, going on for 5 years. Patient does not have a malignancy. It means he has not died. We have given steroid. We have tried to kill him, but he has not died. Hemoglobin 7.6, TLC 2800. Neutrophil lymphocyte ratio with the pancytopenia is preserved. In the last case, lymphocytes were more than neutrophil. In this, neutrophil lymphocyte ratio is preserved. You see how the contrast is playing. Pancytopenia, but the neutrophil lymphocyte ratio is preserved. What next to be done? PS is normal, no left shift, reduce platelet counts. What do you do next? Anybody on the chat? What will you do?
Bone marrow.
Okay, things to consider: chronicity, no response. Bone marrow aspiration versus gastroenterologist. Who will you send this patient to, dear all? Remember, pancytopenia with splenomegaly can never be aplastic. Pancytopenia with splenomegaly can never be MDS. Myelodysplastic, it means cells being broken down. Myeloproliferative neoplasm can have spleen. In this patient was referred to hematologist. Hematologist sent it to gastroenterologist, and the gastroenterologist showed the varices. This patient has extrahepatic portal vein thrombosis, and there was a hypersplenism. So you see the pancytopenia, 2 patients. Lymphocyte neutrophil ratio reversed, neutrophil lymphocyte ratio preserved. The differential diagnosis could have been myelofibrosis, could have been hypersplenism, but the peripheral smear has got shown nothing. Last case, 68-year-old presented with 3 months progressive abdominal swelling, fever, weight loss. Bone marrow outside done was inconclusive. Again, now there's a splenomegaly. Last time splenomegaly was small. This time spleen is bigger. Hemoglobin 6.7, TLC 1000, lymphocyte 90, platelet 12,000. Diagnosis? Think lymphoma. So this peripheral smear shows hairy cell leukemia. This peripheral smear shows this lymphocyte has got hairs. You see, it has got more hairs than my head. This is hairy cell leukemia, and there is no role of steroid. You give cladribine, patient continues to do well. Okay, so that is very important. I've got another 5 minutes to go for. 24-year-old presented with fever 5 days duration. He had delirium, had a toxic look. Evaluation showed basal Krebs. CBC HB5, TLC 34,000, platelet 5. How many of us will give platelets in this patient? How many of us will give platelets in this group? Should we give platelets on the chat quickly? Yes, no. Yes, very good. We should give platelets because very, very important to know where we should give platelet not. APTT, PT done, bone marrow aspiration, biopsy, creatinine was 3, peripheral smear. Should we do bone marrow aspiration biopsy? Because hematologist speaking, yes. LDH is 3,400. Now what it shows is the schistocytes. What it shows, dear all, is the schistocytes. It means the patient has got TTP. Remember, whenever the platelets are low, the peripheral smear, when we say ABC or CBC, we have to have a CBC with peripheral smear and the reticulocyte count. This patient had TTP. Patient underwent plasma exchange plus rituximab, became better. Platelet is contraindicated in TTP. Remember, platelets are contraindicated in HIT. Platelets are contraindicated in TTP. You do not give platelets to such patients. So with this, we come to an end. I will take your questions now. Very important because this can continue to go on for the questions to be taken. So I would invite the questions. This is what I have to share in terms of what we do on a day-to-day basis. Over to Dr. Pawan. 12, we have got 10 minutes more to go by. Please, Dr. Pawan.
Thanks, Dr. Rahul, for masterly presentation. Now, if anybody has any question, then they can put in chat box or can unmute and directly ask the speaker.
Dr. Bhargava, very good presentation. Just one comment from my side. As a pediatrician in iron deficiency anemia, we always give oral iron, never give parenteral iron. So what is your take about that? How much we can treat iron deficiency anemia by giving only oral iron?
Sir, बहुत ही अच्छा सवाल है सर. Very good question. Oral iron is equivalent to IV iron. Rate of rise on iron deficiency patient, oral iron and IV iron will have a same rate of increase, provided 25% people who does not tolerate iron, we have to identify. One, iron tablet has to be given alternate day at 11 o'clock. There's a very beautiful paper of BGH. If you like, I'm on various groups. I will send you all the papers. As my son is in the US, he continues to send me the articles and the books. BGH article says 11 o'clock because the hepcidin levels are all low. Please take 11 o'clock iron tablet, alternate day, not 3 times, not 2 times, alternate day. And you have to keep a gap of 2 hours before and after the medication. दूध, दही, पनीर, हरी सब्जी, calcium और चाय का सेवन नहीं करना. You do not have to take all these things 2 hours before and after the iron tablet. One of the commonest causes of iron deficiency anemia in Haryana is
milk intake.
The social value of taking milk or chai after food. We should dissuade that. We should discourage that. We should encourage people to take iron and food separately. That is what is required.
Thank you, Dr. Rahul. I want to just emphasize this thing, that we should avoid parenteral iron as much as possible.
Absolutely, sir. So, ma'am ne पूछा कि sometimes the iron is low and ferritin is high. Ferritin बहरूपिया है. Ferritin is the marker of inflammation. Whenever there will be inflammation, ferritin will go up. That is why even if the ferritin is up to 200 and the iron is low, consider that as an iron deficiency. You have got fever, ferritin will go up. If you have got a problem, say liver disease, ferritin will go up. So ferritin alone cannot be trusted as the only sole marker for iron deficiency. So it has to be seen in combination. Please remember that.
Sir, basically, IV iron has got certain pressing indications also, like in patients of congestive heart failure, IV iron is mandatory for correcting the iron
Sir,
deficiency. And
sir, simple सी
CKD
बात है.
also.
Yes, sir.
In those patients, IV iron becomes mandatory. But routinely for correcting IV, for IDA, we don't require iron, IV iron. And
जिनकी बाईपास, जिनका गैस्ट्रिक बाईपास हुआ है उनके लिए, क्योंकि वो ड्यूडेनम में एब्जॉर्ब होता है.
yes,
जिनका गैस्ट्रिक बाईपास हुआ हुआ है, जिनको सीलियक डिजीज है, जिनको अल्सरेटिव कोलाइटिस है, उन लोगों में आईवी आयरन दीजिए. नॉर्मल के लिए सर ओरल आयरन इज गुड एज आईवी आयरन, प्रोवाइडेड दे आर एबल टू टॉलरेट इट.
and what about pregnancy and IDA? At what?
The pregnancy in IDA. So very good question, sir. In the first trimester, we have to only supplement with oral. In second trimester, we can give IV. Ferricarboxymaltose is now getting approved. We can do that.
Thank you.
Somebody has asked, can we give IV oral syrup iron? Of course, you can give. All you have to remember is the elemental iron has to be 3 milligram per kg body weight. That is the minimum amount where you have to get it absorbed. So next time I will have one only separate topic, how just to treat iron deficiency anemia with various salts, pyrophosphates, iron sulfate, ferrous gluconate, new fancy nanotechnology iron. We will have a separate this thing onto that, because there's a lot of to discuss which iron is good and which one is to be given in the most effective form.
Yeah, Dr. Rahul, it's right. But as far as you have talked about the celiac disease, that probably
Yes,
the oral iron will not get absorbed. But what we have seen many times when the patient comes and we diagnose it as gluten enteropathy, most of them are anemic, severely anemic. But routinely by giving oral iron only, this anemia gets corrected over a period of time. Of course, it takes some 2-3 months. So, is there any there is anything between these two different entity, as you talked about the celiac disease, and I am talking about the gluten enteropathy?
The gluten enteropathy, we actually tends to use this both synonymously, gluten enteropathy and the celiac disease. So it also sometimes depends on the extent and the disease extent onto that. By the time the patient lands up to us, patient is pretty sick, and the oral iron can add to the gastritis problem. Once the patient becomes stable, as a maintenance strategy, we can use oral iron. By that time, we have removed out his general debility. We have put him off gluten, and the patient has started becoming better because the inflammation has started coming down, sir. The more we take gluten, there's more inflammation. So what we do with our practice is, if these patients are diagnosed, we give them a shot of ferric carboxymaltose to them. And after that, as a maintenance strategy, alternate day or once in twice in a week or thrice in a week, these people are on the iron supplementation for 6 months to 1 year.
Dr.
That's the
Rahul,
inflammation which has to.
is it a thumb rule that iron should not be supplemented on a daily basis?
Sir, alternate day, sir. So now
Yes.
the data has been very clear because of the role of hepcidin, sir. It has to be done alternate day, sir.
Okay, that's nice.
So what about the GI side effects and different preparation of iron? Basically, probably it is related to mucosal block theory of iron absorption. So can you put some light on that?
So the thing is, it also depends upon the total content of the iron which you are taking, sir. Ferrous sulfate, ferrous gluconate, 90 milligrams, 60 milligrams, 20 milligrams. So one is the preparation, sir. That is why they say ferrous sulfate and ferrous gluconate are the ones which are the safest, and the ferrous fumarate. If you're not able to do that, then the nano ones and the delayed release ones can be used. But the delayed release one is bad because it releases beyond the duodenum. That is why the absorption is not good, sir. Then if you are having a gastritis or gastric problem, rather than 90 milligram tablet, come on to a 60 milligram elemental iron thing. So उसके अंदर दवाई के अंदर सर एक टोटल आयरन लिखा होता है, उसके अंदर एलिमेंटल आयरन लिखा होता है. तो अगर फेरस सल्फेट में या फेरस ग्लूकोनेट ने अगर 180 मिलीग्राम लिखा है तो उसमें 90 मिलीग्राम ही एलिमेंटल आयरन होगा. So actually you can start coming on down on the content of the iron through various these preparations, which is first is ferrous sulfate is the gold standard, then is the ferrous gluconate, and then the ferrous fumarate.
Sir, there is one theory of colloidal theory of absorption of iron. So because in body the crystalloid form is probably not that well absorbed, and colloid form is better absorbed. So there are certain colloid preparations of iron which cause less GI side effects. Is there any rationale to that theory?
Yes, sir. Sir, yes, sir. If after doing all these jugglery of changing the brand, reducing the content of the single tablet, these preparations can be utilized, and these preparations are coming fast in the market. But sir, large long-term studies have to be proven beyond doubt, because these are expensive preparations. That is why they are not so readily available and popular right now. But you're right, sir. Those theory remains because of the gastric side effects have been reduced.
And a word about vitamin C and copper plus zinc.
Yes, sir. So vitamin C always has to be supplemented, or an orange juice. You can always take with an orange juice the vitamin iron supplementation, because it helps you to increase the absorption. And the copper, of course, also helps you to increase the absorption. But what should not be taken is the coffee and the tea or the milk.
Because of chelating effect.
Even the calcium, sir. So calcium has to be avoided. So
Yeah,
if you're
calcium
taking
has-
iron in the morning, then the calcium has to be taken in the evening, sir.
Yes, in pregnancy, both are co-prescribed, so they have to be
Yes,
taken
sir.
at different times.
Different times. So the most important thing is the CBC, sir. This report which comes to you actually entails and carries a lot of significance. If we are all on the IMA group, you can always send the report on the WhatsApp group to see what is happening if you are in doubt, because these smaller things and can actually help you to reduce the out-of-pocket expenditure for such patients.
So there is again one more parameter, Menzer index. So put some light on Menzer index also.
So Menzer index is always utilized for making a thalassemia out of it. Whether there is a thalassemia there or not, that's where you tend to use Menzer index in this setting.
It is same as RDW, sir, because ultimately it is the RBC and your hemoglobin that makes the difference. So Menzer
Yes,
index
sir.
is 13. If it is below 13 or above
Thalassemia.
13.
Yes, yes.
So Menzer index is very simple, sir. MCV divided by the RBC, sir.
By RBC.
जो पहली दूसरी स्लाइड में दिखाया था, MCV divided by the RBC is the Menzer index. If it is less than 13, suggestive of thalassemia. If it is more than 13, it is suggestive of iron deficiency anemia.
Perfect, perfect.
बिकॉज सर सिंपल आयरन डेफिशिएंसी में आपका प्रोडक्शन ही कम होगा तो आपका आरबीसी काउंट कम होगा और थैलेसीमिया में आरबीसी काउंट ज्यादा होगा.
Definitely.
Right, sir.
Dr. Rahul, put one question in the chat कि अगर सीरम फेरेटिन हम कराते हैं और वो हाई आता है and still we need to give iron because of iron deficiency, we need to give iron, IV iron, क्योंकि normally हम लोग को बताया गया है कि when you give IV iron, serum ferritin is a good indicator to actually decide whether we need to give IV iron or not. But अगर IV ferritin high आ रहा है, so how, and we see that the other parameters show iron deficiency, how medically or legally are we justified in giving IV iron?
तो देखो मैम, हाई का मतलब लेस देन 200 और मोर देन 200 मान के चलो.
अच्छा.
अगर 30 की जगह वो 150 है, लेस देन 200 के साथ में अगर आयरन के पैरामीटर्स टीआईबीसी बढ़ा हुआ है, परसेंटेज सैचुरेशन कम है, वो आयरन डेफिशिएंसी ही है.
All right.
Iron, ferritin is a storage form. Let me put it this way.
Yes.
Ferritin is a storage form which is in the liver. If you have an inflammation, it will push it up. But if your serum iron, serum iron is low, TIBC is up, as well as the percentage saturation is low, it is iron deficiency anemia, ma'am. Then you do not get the ferritin.
Right.
What you are trying to say is once these parameters normalize, iron normalize, TIBC normalize, percentage saturation is good, then ferritin is low, that is iron deficiency. If ferritin is less than 200, it could be iron deficiency. But if it is more than 200, it will not be iron deficiency.
ठीक है. तो ferritin कराना medico legally जरूरी नहीं है before giving IV iron?
Absolutely, ma'am.
Right. And pregnancy में भी we have to give iron on alternate days or what?
Ma'am, alternate day. First trimester में alternate day ही देते हैं, so that nausea vomiting को हम कम कर सकते हैं.
And later on in the second and third trimester?
Ma'am, second and trimester में अगर low है, IV iron is a good choice in second trimester. One shot will be good enough. But अगर वो नहीं है, तो alternate day iron आप continue कर सकते हैं.
All right. Thank you. Thank you.
I think Dr. Rahul, ये mindset बहुत जरूरी है because of hepcidin effect. Alternate day
Yes, sir.
and daily, the absorption is same. It is the mindset of doctor कि if you give alternate, then the effect will be less. Effect will be same.
यस सर, एब्सोल्युटली सर। काफी सारी ट्रायल्स में मैं बीजीएच का आर्टिकल भेज दूंगा सर। एक
Yes,
बहुत अच्छा आर्टिकल है आयरन डेफिशिएंसी एनीमिया पे, आप उसको देख लीजिएगा। इट इज अ गुड आर्टिकल।
If there are no more questions, then probably we would.
Sir, I want to ask something. Have you observed mixed deficiencies in dimorphic anemia in bone marrow, saying megaloblast also and micronormoblast also?
वेरी इनकॉमनली सर, अपने न्यूट्रिशनल डेफिशिएंसी जो होती है सर, उसमें दोनों होते हैं, माइक्रोसिटिक भी होते हैं और मैक्रोसिटिक भी होते हैं। इसलिए अगर किसी को आयरन डेफिशिएंसी एनीमिया है तो B12 उसका चेक कर लो। एक और कारण विटामिन B12 सर, अभी हमने कुछ पॉइंट्स पे टेस्ट नहीं किया। अगर विटामिन B12 इवन आफ्टर सप्लीमेंटेशन इज कमिंग हाई, इट्स अ मार्कर ऑफ माइलोप्रोलिफरेटिव नियोप्लाज्म। किसी को कोई आयरन टैबलेट नहीं, विटामिन B12 नहीं मिल रहा, उसका विटामिन B12 हाई है, इट्स अ माइलोप्रोलिफरेटिव नियोप्लाज्म। बट अगर आप ओरल आयरन सप्लीमेंट कर रहे हैं, ओरल आयरन सप्लीमेंटेशन के साथ में फोलिक एसिड और विटामिन B12 दोनों सप्लीमेंट कर दीजिए। हमारे नेशनल एनीमिया अवेयरनेस प्रोग्राम में सर विटामिन B12 का कोई हमारा से नहीं है, जबकि अपन वेजिटेरियन लोग हैं सर। आयरन के साथ में विटामिन B12 की भी डेफिशिएंसी होती है। अमेरिकन ने कहा कि विटामिन B12 के साथ फोलिक एसिड दो, तो उनको लगता था विटामिन B12 क्योंकि वो नॉन वेजिटेरियन पॉपुलेशन थी। हमारे यहाँ पे सप्लीमेंटेशन में विटामिन B12 और आयरन दोनों साथ में देना चाहिए, सो दैट वी कैन डू अ बेटर जॉब इन इंक्रीजिंग द हीमोग्लोबिन।
Thank you, Dr. Rahul. It was a very nice and lucid presentation. And definitely, our delegates are also increasing with each episode. And there is a demand for the recordings and to put them on YouTube. And I again request Dr. Kavita and Dr. Pawan Goyal to make it possible so that more people can be benefited by this. And definitely, as Dr. Rahul has told, that we should, first of all, a simple CBC report has to be read thoroughly, with each indices has to be read, and then we can make a lot of diagnosis by a simple CBC also. But definitely the peripheral smear is one thing, probably still we are not very sure how the pathologists or the labs are doing justice with the peripheral smear. That is one thing. But otherwise, a lot of information can be taken out from the simple CBC. And at least we can, if we cannot clinch a diagnosis, at least we can go near to a diagnosis. And if there is any problem, definitely we have so many of our hematologist friend where we can just approach to them, and we can just take out their advice also. So it was very nice. Thank you very much, and thank you all the participants for sparing your time and putting up your invaluable suggestions also into the chat box. Thank you very much.
Sir, finally, I would request our secretary, Dr. Soni, to put a vote of thanks for everybody present here, and especially to our speaker, Dr. Rahul Bhargava.
I take this opportunity to thank Dr. Rahul Bhargava for an excellent session. I thank Dr. Pawan, Dr. Kavita for carrying ahead with these sessions. I thank all the participants. I think we need a YouTube parallel to this if we are exceeding 100. So YouTube link can be done.
We will try this week also. And next week, sir, we have a scintillating session on dementia with Dr. Manish Mahajan. Everybody is requested to attend that session. That would be probably one of the most wonderful sessions which is upcoming next week. Dr. Manish Mahajan is the senior neurologist. He was working with the Artemis Hospital.
Can we do a YouTube live next week?
YouTube साथ में.
We will try, Dr. Kavita.
Thank
you everyone.
We will try.
Thank you so much.
Thank you everyone. So I am
Thank you, sir. Thank you.
signing off. Thank you.
Dr. Rahul, one more request. If you can just give us a write-up of some 2 pages or 3 pages about your presentation. That will be very
I will do that,
nice.
sir.
Yeah. And about
Sure, sir.
thalassemia, we will discuss.
Sure, sir. I'll come to you, sir.
Yeah, please. Thank you so much.
Thank you.
Thank you,
Thank
sir.
you, everybody.
Good night.
Good night.
Thank you, sir.